To illustrate these challenges, I just want to talk you through four examples from different areas in data science and healthcare, one of which we saw on Monday, but I'll go into a little bit more detail now that you've had your crash course in machine learning and data science this week. But let's start with an example from medical imaging. So this is an example from a team at Google who worked on building an AI system to detect diabetic neuropathy. Or sorry, diabetic retinopathy. Sorry, I'm working on a project on neuropathy. Diabetic retinopathy. So diabetes is a highly prevalent disease. And among patients who have diabetes, a third of them have diabetic retinopathy. And so what that is a condition of the eye. It causes lesions and can lead to blindness. So this is like a very serious condition that affects a lot of people. And screening is done quite frequently. So like every twice a year or once a year, retinal images are taken and they have to be manually interpreted. So someone who understands how to read these images has to sit down and actually interpret them. This is highly time consuming. There's actually a shortage of people who can accurately read medical images. So there's been a lot of work trying to automate this process. How can we make it more efficient, more reproducible, and like increase the coverage, right? If we could make it more automated, we could potentially screen more people, help more people. And so this is a problem that was tackled by a team at Google a number of years ago, just using data at Google, building a deep learning model to detect diabetic retinopathy. And it was actually able to do so at a human specialist level. So like a sensitivity of like 97%, a specificity of 94%, very, very accurate. And so the next step was to really use this algorithm in practice. So in sort of our computerized world at Google, it worked really well. But if we actually brought this to the front line in healthcare, could it work? It actually turned out it couldn't, interestingly. So they did a trial run of their algorithm in 11 clinics in Thailand. Thailand was chosen because diabetes and diabetic retinopathy are highly prevalent, and there's also a shortage of people who can read these medical images. However, it turned out about a fifth of the images couldn't even be read by the algorithm. So the lighting in the clinics wasn't very good, the images were taken too fast. And what the algorithm said when this couldn't happen is, we'll send the person to a specialist, send them to a follow-up. This led to a lot of unnecessary scans and specialist appointments and kind of defeated the entire purpose of this automated procedure. People in Thailand had to travel long distances to go to specialist appointments they need, and it didn't solve the problem. So Google is taking this pilot study and trying to actually improve how this algorithm functions in practice. But this is just to give you a sense of sort of the gap we see between sort of machine learning and our nice world living in sort of what you guys have been doing in collab, but then actually trying to take that algorithm and use it in real life. There can be a huge gap. And maybe you've seen a bit of this and like teaching your car how to drive. It's very, very difficult. So that was an example of a highly accurate algorithm that didn't pan out well in real life. But in other examples in healthcare, we have issues before we even get to building the algorithm. Because sometimes it's even so challenging to get to that step. And so we'll talk about next another form of health data, electronic health records, or EHRs, which are very, very popular nowadays. You've probably heard a bit about them from the different speakers, but just to remind you guys, an electronic health record is exactly what it sounds like. It's an electronic record of a patient's interactions with a healthcare system. So like as you or I go into the doctor, different information is recorded about us, things like demographics, how old we are, what is our race, as well as like diagnostic procedures, labs, meds that are given to us when we see a healthcare provider. And a huge information is actually written in free text. So what are doctors writing about you? What are your signs and symptoms? Why are you there for the visit? And so when we have this data, what we always have to remember is it's a byproduct of clinical care. So unlike the example I just gave you of medical images that are specifically taken to diagnose a given disease, like this health record data is not going to be generated for whatever purpose it is that you want to use it. It's just data that's collected as patients go in and out of the hospital. So if I want to build an algorithm to predict if you're going to get sick, I didn't design the study specifically for that purpose. So we face many challenges in data. This is called observational data within data science. But from one angle, having this data that's just recorded, as a byproduct of our everyday interactions with the healthcare system is like really a blessing. The data itself is much, much bigger than you would have in any sort of traditional setting. You have longitudinal data, so data collected over time on huge populations. Like I just showed you, you have information on numerous fields. Also, the data you have is on real patients receiving care. So potentially very generalizable population. And over the years, EHRs have been adopted just worldwide. So there's tons and tons of electronic health record data. And ultimately, the goal here is to use this data to improve patient care. So to help better treat patients, like what I described to you, and why work in healthcare? Why would you go into this space? And that article that I just showed you was from the Wall Street Journal, and it emphasized this idea of what's called a green button. So it would be a tool embedded in a healthcare system that a physician could just press, and it could present to them patients like theirs, what treatments were effective, what treatments weren't effective, what sort of symptoms are similar between these patients, to help them make better care decisions and potentially identify unanswered questions that could benefit from some sort of traditional clinical study. But as most of us know, when you go to the doctor, you don't see them, them pressing a green button. And this idea was proposed almost 10 years ago. It still doesn't exist. So you might wonder why, like, why aren't we there in healthcare? What's the issue? Why can't we use this health record data? And so it turns out this very idea of identifying patients like mine is, while seemingly simple, is extremely challenging with health record data, or EHRs. And this is because they don't have explicit information on what are called phenotypes. And so phenotypes are just patient characteristics that you can identify from an electronic health record. So like really basic things you need to understand. Does someone have a disease? Say, do they have diabetes or not? How severe is it? Is it type 1 or type 2? When did they get it? How has it progressed? Did they respond to treatment? All of these identify and characterize any population, right? They're very basic concepts, but unfortunately, I can't just extract them easily from the data. I have to go to a lot of work to even figure out who are patients like mine? What are their phenotypes? And so from a high level, we can understand this by just sort of how the data arises. There's sort of two flavors of electronic health record data. The first is structured. So this is data that's like very easy to extract. So it's living just in a database, so like kind of similar to the data you've been working with this week. So things like demographics, diagnosis codes, why were they at a provider, their lab values, medications. But this data often lacks like a lot of context. It's easier to work with, but it lacks context. This can be something we see commonly in healthcare data science. So just to give you an example, a diagnosis code. So this is like given to a patient as they come in the system to denote like what was the reason they were there? Why were they seeing the physician? This doesn't actually map to the diagnoses they have, and there are multiple reasons for this. This could be because the disease itself is like complex, so it takes a long time to diagnose. So for instance, I've worked on rheumatoid arthritis. As this disease gets diagnosed, it can be confused with osteoarthritis. So patients could be coded for that disease, but not actually have it. So we have like a ton of noise. Also, diagnosis codes are tied to reimbursement. So there's a lot of upcoding. So for instance, certain diseases get higher reimbursement. You might be coded for that disease, even though you may not have it. There's also a temporal shift in the data, which we saw on Monday. So coding systems can change. So the main coding system for diagnoses in healthcare went from like 13,000 codes to like 48,000 codes a few years ago. So it's a huge shift in the data that we have to account for in any of our analyses. Where a bulk of the information, however, though, is in these clinical notes, which is unstructured data. So free text, which you haven't seen in our program, but it's data that's like very difficult to work with. It's very rich, so it'll contain information that's not in structured data. So like, for instance, if a patient goes out of the system, we might have that written in a note somewhere, or family history might be written in a note that might be useful. However, this requires like natural language processing, or NLP, to analyze. So we have to go do a lot more work. So for instance, just trying to extract like the word rheumatoid arthritis from a clinical note, it's not just a simple keyword search. There's many ways that physicians can write rheumatoid arthritis. So there's this whole dictionary of like almost 1 million what are called concepts, which are umbrella terms for how physicians write these words. So like rheumatoid arthritis can have the abbreviation RA. It's mapped to the same concept in this dictionary. You also have to worry about things like, was it a positive mention? The patient does have RA, or a negative mention, the patient doesn't. Family history, so all sorts of complexities that arise in this data. But as you can imagine, right, like someone's phenotype is contained in both, right, structured and unstructured data to really precisely characterize what conditions a patient has. We have to mine all of this extremely, extremely messy data. And so in healthcare so far, figuring out patient phenotypes, which are done with what are called phenotyping algorithms, have actually been like hand curated by physicians. So they're rule-based, meaning it's just like a system of rules physicians come up with and say, okay, if you have this code or this term or this lab, then yes, you have the disease, otherwise no. And they look like flow charts like I'm showing here. And so you can imagine they're like pretty simple to use. They can be highly accurate. Physicians are extremely smart. They know the diseases really well, but it's really hard to scale. Every disease, we need to build one of these flow charts. It's extremely challenging. They can take years, thousands of dollars of funding to do this. So of course, a potential solution is to try to automate this with machine learning, right? This is essentially what you guys have been learning to do, is like, we want to learn the relationship between some features and an outcome. That's the job of a learning algorithm. Why don't we let the data sort of tell us how to do that? Well, this process is extremely challenging just at the first step. So to get training data, the information on the outcome why is so hard in healthcare. We actually have to ask our physician friends to sit and read medical charts for us, which they hate to do. And it can take like 45 minutes to get one label. They have to read all the records of a patient. So we're in a setting where even getting a training data set to build that learning algorithm is a huge obstacle. We need to do better. We need to think of another way to solve this problem.